If you remember last week, we talked about some of the different ways to communicate the scale of a health problem. I think this week's lecturer, Dr. Ahembisabwe, did a fantastic job of encouraging us to think critically about the issues surrounding this week's topic, maternal health. He used his experiences in Uganda to really bring the topic to life and humanize the women who are bearing a disproportionate burden of disease around the world. The readings for this week cite the maternal mortality ratio at Mulago National Hospital at 600 per 100,000 live births. Similarly, Uganda's neonatal mortality rate is quite high at 29 per 1,000 live births. So how do we convince someone to take action to improve this situation? Dr. Ahembisabwe uses a narrative to describe his first-hand experiences in dealing with maternal health issues in Uganda. The readings describe some financial barriers that face patients, despite the availability of publicly funded hospitals. He describes a situation where his aunt was in labor and trying to navigate the fragmented healthcare system. Doctors told her they simply did not have the proper drugs available, so Asa went and got them for her. Not only do patients have to bring their own medications if the pharmacies are out of stock, but they also have to bring their own bedding, food, and they may even have to pay for their own lab work if the lab machines at the hospital are broken. Asa's aunt was lucky enough to have a family who could afford to fight for her, bringing her to doctor after doctor and paying for the care that she needed. I was shocked to hear Asa say that the wait times for an emergency C-section can range from 8 to 12 hours, with some women having to wait up to 2 days for an emergency C-section. This is unheard of in Canada. It's not surprising, then, to find out that the leading causes of maternal death in Uganda are infection and postpartum hemorrhage, followed by teenage pregnancy and complications from abortion and miscarriage. As with many of the issues that we talked about this semester, these problems can seem so big that they might seem insurmountable. How can you even attempt to improve outcomes when operating rooms have no running water, hospitals have far more patients than beds, and decision makers are turning a blind eye because the lives that are being lost are clearly not valued in the eyes of society?
This image depicts a practice called kangaroo mother care. It's defined by the World Health Organization as early, continuous, and prolonged skin-to-skin contact between the mother and the baby, while also incorporating breastfeeding, early discharge, and follow-up support.
It's a practice that was developed in Bogota in Colombia, and it's shown to be equivalent to good conventional care in terms of outcomes. So in low-resource settings where there isn't access to good conventional care, kangaroo mother care can have a significant impact on outcomes. What impacted me most about Dr. Ahembisabwe's lecture, though, was not the high rates of maternal or child mortality. It wasn't about the issues that Ugandan women face in childbirth. It was his passion for what he does. He's not afraid to stand up in front of politicians and decision makers and fight for women's rights. He is so passionate about helping people that when there was no blood in the blood bank for his patients, he stuck a needle in his own arm to give his own blood to 4 different babies. This is the kind of passion that I think is needed to make change on a global scale. I can only hope that one day I'm able to find something that I'm this passionate about and to spend my life working to make a difference.